marijuana, the other half did not, the ones who actually got marijuana had a significant decrease in the dosage of their prednisone. So there's actually a really good anti-inflammatory effect. That was an interesting study. So I mean, I don't use it for that, but it's an interesting piece of information as well. Not so much for treatment of hepatitis C, but the symptoms of hepatitis C: pain, weakness, anorexia, nausea, those kinds of things. Patients on hemodialysis, they lose a lot of weight. It's a very catabolic process, and they can use that as well. A post-traumatic stress disorder was it was just added as an indication. I think it was in 2015. Like I said, if you use a lot of THC, heavy marijuana, it might actually make things worse. It makes you more anxious, more jittery. But a high CBD type of marijuana can sometimes calm down nervous and behavioral disorders as well. I do want to say, I mean, the issue with medical marijuana is that it hasn't really been very well studied, mostly because there's not a lot of places where you can get it for study. For a long time, the only place that you could get medical marijuana if you were a university researcher wanting to study it was University of Mississippi. For whatever reason, they were the spigot. And even then, they limited, the federal government limited how much marijuana was being made available. So we don't have a whole lot of information. However, many people use it, and there is some data on what the potential toxicities are. Interestingly, whether or not you take a particular kind of product determines the toxicity. Many people will use natural medical marijuana, but there's also synthetic, Marinol, Sativex, things that are approved in other countries but not in the U.S. And if you use natural medical marijuana, presumably it has the 78 cannabinoids, the kind of side effects that you have, if you have side effects, are different. It ends up being more things like central nervous system, anxiety, sedation, hallucinations, memory defects. All that tend to be CNS-based. Whereas if you take the synthetic cannabinoids, while you do have some nervous system effects, you also have things like metabolic, nausea, vomiting, hypokalemia. I will say a couple of things. Although we use medical marijuana to treat nausea and vomiting, there is a syndrome called cannabinoid hyperemesis, which means that if you take medical marijuana, paradoxically, it actually makes you throw up. And so if that happens, stop. Right? But it's been associated with ER visits for patients who, we figured they were nauseated, they take more medical marijuana, but then they kept being nauseated, so just be careful. And then also, one thing that I do want to say as well in terms of how to take marijuana, there's a whole bunch of different ways to take medical marijuana. You can eat it, you can, as an oil underneath your tongue, all these things. One thing that I don't recommend for anybody is to smoke it. For a couple of reasons. One, I see lung cancer patients, and in general, I don't like things that get smoked. But also, medical marijuana, because there is no regulation, there's a high likelihood of organisms in the dry, the leaf. Bacteria, fine, but the scary one is Aspergillus. And other kinds of fungal organisms. And if you're somebody who's getting chemotherapy, therefore immune suppressed, or you see it a lot, or have been reported in patients who are going through bone marrow transplants, they can be immunosuppressed for quite a long period of time, and then they're also nauseated, they're also not eating, and if they take their marijuana in the smoked form, they can have some uncontrolled Aspergillus infection. So there's a couple of caveats. It's not super safe. It's generally safe. No one's ever died of a marijuana overdose as far as we know in the United States, but there are potential toxicities associated with it. All right, just a couple of more minutes. Let me just do the logistic legal part. It's still illegal in this country. It's still considered a Class 1 or Schedule 1 drug, along with heroin, LSD, peyote. Interestingly, the Schedule 1 means illegal, there's no medical purpose, we shouldn't be prescribing it. Schedule 2 means, all right, should be controlled, but there's actually medical uses for it, which includes cocaine and methamphetamine. Interesting. Cocaine's an analgesic, or an anesthetic, so we use it for that. Methamphetamine can help with certain behavioral problems. Anyway, so just an interesting thing, and a lot of as I researched it, there's a whole library of information as to why medical marijuana got to this point. Much of it is corporate, much of it can be considered to be cultural and race-based. But the bottom line is, even now in 2017, despite rumblings to the contrary, medical marijuana is still considered to be a Schedule 1 drug. Now, the American Cancer Society is a little softer on that. and it says that it should be studied. There does appear to be some medical benefits in certain situations, so it's a little bit softer. However, officially, right now, the DEA still can, if they wanted to, they could. However, the guidance so far, even in the current administration, is not to spend resources in looking for patients with medical marijuana dispensation. But what does that mean if you're a patient who wants to take medical marijuana, or if you're a provider who thinks a patient is appropriate? I mean, you have to kind of make sure that you can kind of do this appropriately so that there's no questions. And really, it's just like any other drug that you would prescribe. You want to make sure that you're doing it and documenting, right? Establish the patient-physician relationship. Probably best if nobody comes to you and then you give them marijuana right then and there and you never see them again. That seems kind of fishy. The same thing is true with opioids. The same thing is true with any other medications that are available. And more importantly, and this is kind of important for me, identify what it is you're giving marijuana for. There's a lot of questionable indications for medical marijuana. The data, even on things like nausea and pain, is good but not great. But there are people who are taking marijuana, like for instance, oh, this will cure your cancer. And for that, unfortunately, there's absolutely no data. Has anybody heard of things like Rick Simpson oil or Phoenix tears? Very high concentrations of medical marijuana. And it's being marketed as an anti-cancer drug. And unfortunately, there's no data on that. It'd be great to study it. I mean, there's anti-inflammatory benefits, so maybe we know that cancer interacts with the immune system and inflammation, but there's just no data. And so what I tell my patients is, yeah, I'll give it to you, but for specific indications, and we know exactly what those are. And you document attempts at other medications. Like I said, it's a modest pain medication. It's better than, it's not as good as opioids. However, what it can do is hopefully decrease a patient's reliance on opioids. Right? It's a modest antiemetic, but what it can do is maybe make it so you're not taking your Zofran or your Compazine as often as before. The one thing that I do tend to use as a primary medication for is for anorexia, just because the medications that we have, Remeron and Megace, they're not very effective. Megace has some data in HIV patients, but even then, it's not great data. And so I try it. If it works, great. If not, there's not a whole lot lost. But more importantly, document whether or not it works. There has to be a line in your assessment and plan that says, all right, we're trying it for this. Patient's been on it for 2-3 months. It's working. We keep going. Or it's not working. We're going to do something else. Okay. As far as what you need to do, I'll show you the paperwork for it. But basically, last year, the medical marijuana laws changed here in Washington. They changed again earlier this year, but not as big as last year. Last year, basically, it got rid of the distinction between recreational marijuana dispensaries and medical marijuana dispensaries. They're all just marijuana dispensaries now. However, it made a special provision for patients who are medical consumers of marijuana as opposed to recreational. And so if you qualify as a medical marijuana patient, your physician will give you a certificate. It's not a prescription. It's called a certificate that says it's okay. I'll show you what that looks like next slide. But then you can take that to a marijuana dispensary that has a consultant or a medical consultant sort of certificate. In order for a medical dispensary to have the consultant certificate, they actually have to go through a 20-hour class. They have to know CPR. They have to sort of have some information on the medical uses of medical marijuana. They can't tell you you should use this for your particular disease, but what they can do is once you get there, they can give you information on, well, this one might work, this one has been known to do this. They can sort of give you guidance on which strain of medical marijuana might be helpful. If you do that, you have one of two options. Either you give them this certificate, which you get from your physician, and with this certificate, you can either just right off the bat, get a little bit, or get the same amount that anybody else can get recreationally, except you don't have to pay the 37% tax, or if you let them enter you into medical marijuana database, it increases how much you can buy all at once. And so for a patient who is a medical marijuana patient, just by virtue of having the certificate, you can already get the lower price. However, you can't get a higher amount compared to whoever's getting it recreationally. I think it's like 1 ounce of marijuana. It's like 16 ounces of a marijuana solid, 72 ounces of a marijuana-infused liquid. If you get entered into the database, you triple that. You can get 3 ounces of medical marijuana, and then whatever 3 times 16 and 3 times 72 is. Of both the solid and the liquid. So it provides, it's just more convenience. Also, if you're a medical marijuana patient, you can grow your own, plants. If you're not in the database, you can grow like 2 or 3. If you're in the database, you can grow somewhere between 6 to 15, depending on what your physician says. And so that's the main benefit for being a marijuana patient, as opposed to just doing it recreationally. Okay. There's obviously a lot more information out there, but I hope I was able to give you kind of a quick rundown of the circumstances under which you would use medical marijuana in cancer in particular, but medical setting in general, and the practicalities of being both a provider who will use medical marijuana for their patients, and also a patient and family member who will use it as a part of their treatment. Thank you very much.
Get your questions ready.
Yeah. So again, for those folks here in the room, you've got some note cards on your table, and just raise those up and someone will come by and pick them up. Lots of questions I can see. And for those of you online, feel free to put your questions in the comment section, and we have someone who is reading those to get to this.
Do you want to write it?
Thank you. Thank you.
Okay.
All right, lots of great questions. Got the I have one for Dr. Mm-hmm. So, Dr. Pujari, I wanted to start with you. So if you have a skin test diagnosis and allergy to mushrooms, can you take Creston?
No, I wouldn't. So the question is, if you have an allergy to mushrooms, would I recommend taking Creston? And I would not. Yeah. Thank you.
Thank you.
We also have another question. Dr. Pujari has to leave a little early, so we're going to front load her. But about turkey trot as well. So one would think that if it was in use in Japan for so many years, there would be data on those breast cancer patients doing better than in the U.S., even with the.
Can you re-ask the question?
Do we have any data from Japan on, except for that one study, more recent data on whether patients using the turkey tail, I said trot, Thanksgiving on my mind. Turkey trail, thank you, turkey tail, whether there are benefits shown with the new chemo as opposed to the one study that you mentioned before. I mean, if it's
so there are a total of 4 studies that I'm aware of for breast cancer with turkey tail. The 3 best I presented to you, so those 3 were on those slides. So there were 3 studies I presented out of the 4, and those are what we have. The NIH has currently approved a grant to some researchers who are currently studying in the U.S. Turkey tail and in one of those extract forms for breast cancer patients, but that data is still being, we're seeing those results. So that's the data we have. I don't have any other data to present at this time. Yeah.
So I apologize. We're going to kind of bombard you a little bit with some questions since we know you have to leave. So do you think that there's any benefit for turkey tail to ER positive? It seemed like most of the information was ER negative.
Yeah, so the studies that I presented to you were for stage 2A ER negative patients that we saw that data. I actually think, given, in medicine we have in internal medicine, we get pushed a lot into evidence-based medicine. And evidence-based medicine means what are the studies to show or show something is for or against something. There's a great article in the British Medical Journal that I really appreciated, and it's a study on people. They do a study, which is a meta-analysis, where they review all of the data that's available. And in this study, the question they are asking is does it save lives to use a parachute when you jump out of a plane skydiving? Okay, this is the question. And the answer, based on the meta-analysis, is there is no data to support using a parachute when you jump out of a plane. So the reason that I really appreciate that study and that they actually published it was to show us that actually this idea that we have to have data for everything is actually a misconception, because it's completely unreasonable from a healthcare cost standpoint to force us to try to prove that everything needs data. Where we need, in my opinion, to prioritize our healthcare dollars on the things that are the most risky and the most possibly toxic to patients, which are oftentimes pharmaceutical medications. And I'm not saying herbs are, universally safe either. But when we see here that there's, since 1977, quite a bit of use, and we see that safety profile, I start to wonder, is actually that the best use of our healthcare dollars? I really do, because maybe we should reprioritize. Already we're spending so much money in this country on healthcare, as we know. We're so high as it is. And I think maybe we should be studying surgeries more, or chemo medications, all these things we have prioritized. Those things, I think, we're spending money where the risk is and where that data actually really makes an important difference. So then we go back to not only is there data, but also is there a risk? And I would say the safety of it, I think at this point, looks pretty good. So I don't see the risk to safety profiles. Another thing I really measure when I'm seeing patients, when I'm evaluating, is a therapy, first of all, is it going to interact with other medications? And second of all, what's the safety profile? And I think, because based on that British Medical Journal, we don't have data to prove that the apple you just ate for lunch is safe, or the banana. Do you see what I'm saying? So I think we also have to go back to our human common sense when we're thinking about this thing. So the short answer is, I think it's reasonable to try turkey tail and see. That would be my answer. From a common sense. We're just going to common sense here. I can't give you data, double-blind randomized control trial for that. Does that answer the question?
Yes,
Okay,
thank you so much.
Dr. Rudolph, we have quite a few questions actually on acupuncture and neuropathy. So
We'll share.
you
Yeah.
so
Neuropathy.
can we talk about that a little bit?
Well, I guess I'll assume for the purposes of this conference, we're talking about neuropathy pain in the torso, mostly around post-surgical. Oh, and hands too. Yeah.
Yeah.
Good point.
Head, shoulders, knees, and
Okay.
Oh.
Oh, and the legs too. Yeah, it's so neuropathy is one of the conditions that I had in mind when I referred to the use of electrical acupuncture, in my experience, being pretty important to get results in terms of perception of pain reduction. And so, for me, if I couldn't do electrical acupuncture for a patient with neuropathy symptoms, I wouldn't do acupuncture on that. I wouldn't expect it to be helpful. When the patient is patient with the process, usually we can get some results on neuropathy. It's like I said, it can take time. 4, 5, 6 sessions is what I tell them on the front end to expect, and occasionally I'll get someone who will start to get benefits sooner than that after a visit or two, and that's a good thing, pleasant surprise. But more often than not, it's let's wait until we get farther in. But it's not a guarantee, so you just have to, again, I agree with Dr. Bajabi's statement that sometimes we just want to prioritize safe treatments and say this is something that If you don't mind coming in, investing some time and energy in this, I've had some patients do well. I've had some that didn't respond so terrifically well, but it's not going to make you worse. And you know, people make a choice based on their own individual factors, you know, whatever those are, and a lot of it is the logistical stuff. But I always feel comfortable saying, let's try it, you know, if the patient's open to it. And they generally get the secondary benefits that we've both talked about as far as the relaxation and hopefully the, you know, psycho-emotional benefits that maybe justify sticking around, even if the neuropathy isn't dramatically better.
Great, thank you. Samantha, there's been a few questions in regards to increasing lymphedema risk when you're going through massage therapy. Can you talk a little bit more about that?
Yeah, that is definitely there, which is why I really emphasize finding yourself a trained practitioner with oncology massage.
And actually, let me add to that since you just brought that up. Is there a list of medical or oncology trained massage therapists?
There's the Society for Oncological Massage, which you can find if you Google them, and they kind of band together that way. The other thing is with the training, it really depends on what specifically you're looking for as well. If you're looking for a certified lymphatic drainage specialist, those trainings have sites where they also list all the people that have graduated from those programs. So it depends on what specifically you're looking for. But if you want a general oncology massage resource, I'd look at the society there first. You can also always contact the AMTA, which is the American Massage Therapy Association, and they can also give you guidance that way as well. And there's also a Washington Association of Massage Therapists as well that you can contact. So the other question was?
In regards to lymphedema.
Lymphedema, yeah. So yes, it is definitely a risk that you can increase lymphedema and make it worse if you get someone who's not trained. Usually that comes from doing deeper work while someone is prone to lymphedema or when they are currently having an episode. So that's usually when you see that. So basically, it's the lighter work is always doable, but the deep tissue stuff and some of the scar tissue working stuff may not be.
Great.
So,
thank you.
Thank you. Dr. Rosales, we have a question about whether medical marijuana has any effect on your eligibility for clinical trials.
It can, depending on the clinical trial. Because a lot of times those things are very specific. Even other sort of complementary and alternative medications that shouldn't really be an issue, they want to exclude. And so it really just depends on the clinical trial. Doesn't mean that if you have medical marijuana, you can't ever be on one, but you probably can't continue it for some of them. There are some that don't really care. It just depends from trial to trial.
Great. And is Dr. Rosales again, is there any interaction between CBD and aromatase inhibitors?
As far as we know, no.
Okay.
But that's one of those things that there's no data.
Yeah.
There's not a whole lot of studies. That's unfortunately one of the issues with the use of marijuana for medical purposes is that there's not a whole lot of randomized controlled trials. You know, like for instance, again, we were talking before about the nausea and anorexia and everything. The meta-analysis on anorexia had a total of 244 patients. And based on that data, we figure it's probably not a bad idea to try it. So there's not a whole lot of information out there. The data probably is most robust for nausea and pain. Like for instance, for pain, if you do all there's like 28 different studies, there's about 2,500 people across the board that have been studied with regards to medical marijuana and pain. But unfortunately, when it comes to these kinds of things, like interactions, we don't have any of that information at all.
Great.
For Ms. Bachman, can you be specific about acupuncture for lymphedema? We have a lot of lymphedema questions.
Sure, yeah. So acupuncturists would never needle into the area of lymphedema, so that's important when there's a flare. I would always treat peripherally, and It varies with each individual. Chinese medicine is not a one-size-fits-all type of system. In every visit, I didn't mention earlier, acupuncturists will feel your pulse in several different locations, basically 3 positions at 3 depths on both hands, as well as look at your tongue to determine your diagnosis. And really, depending on what's going on with each individual person, the treatment for something such as lymphedema may be completely different. So there's no one-size-fits-all protocol. It's very individualized medicine, but I have clinically seen improvements in my practice in patients.
Great, thank you. And then we've got a couple more, and then we'll wrap up. In regards to how to avoid or give some relief to scar tissue after a mastectomy, is like acupuncture or massage therapy, or maybe both? Can maybe the 3 of you kind of take a minute to?
Yes. Yeah, massage can really, really shine there. Obviously, it's going to depend on what your specific situation is, but obviously with mastectomies or reconstruction, a lot of scar tissue involved there. And again, massage can definitely really help improve the mobility of that scar and kind of reduce the adhesion, so it's less like super glue to your skin, and work on that mobility, which will then increase range of motion as well. So, yeah.
Thank you. Ms. Johnson, is there any relation, do you think, between Reiki and meditation? Is it possible that those 2 practices link the health effects?
Yes, definitely, because they're both really working on the cellular level. So when you're meditating, you're bringing in that positive energy that's coming through your system, and it's energy medicine. And the same with Reiki. Reiki is also working at that cellular level with it throughout your whole body as well.
Great, thank you.
Well,
I can say one more thing about the scars. If you're not in an acute phase of healing, and it's kind of at somewhat of a baseline level, and it's just kind of a persistent pain, there is a technique that I've used successfully that was kind of something I learned in a context of acupuncture treatment, but it's actually more of non-acupuncture adjunctive treatment using injection of lidocaine underneath the scar. And it can serve as like a deactivation of that hypersensitive area of nerve under the scar. And so that's kind of an adjunctive technique that I use, not in the acute phase of the healing of the scar, but for a chronic area of hypersensitivity, which is common with surgical scarring and other forms of trauma as well.
Thank you all for the questions. Thank you all to our panel for giving us some great information. If you have additional questions for them, they'll be out. You can try to connect with them afterwards. Thank you.
Thank you.
Thanks, guys.